Thanks everyone for having me back this year. It's a pleasure to be here. This is my second year in Minnesota and my second year here at this conference, and both have been wonderful so far. Again, my name is Tanya Glaser. I'm a pediatric ophthalmologist and strabismus specialist at Northwest Eye. We have a fantastic group there. We have four pediatric ophthalmologists, three of which do adult strabismus, and that's what I am going to talk about today. So last year I talked about updates in pediatric ophthalmology. This year, because now I have kind of 2 years of experience and data here, most of my referrals from our colleagues, our optometry colleagues, tend to be this adult strabismus referral. So I was going to talk to you more about updates in that domain today. I have no financial disclosures, but I did want to let you all know there will be some surgical videos included in the talk today, so if you're squeamish at all, just be aware. And we're going to jump right in with a case which I think you guys have all seen, sounds very familiar. This is a 74-year-old male. He presents with 6 months of worsening double vision at distance, and this has kind of gotten worse gradually. He notices the double vision mostly when he's driving, when he's watching television, looking at signs far away. He reports that his near vision remains really good, single, not much double vision, and comfortable. It resolves if he closes either eye. And his past medical history is notable for hypertension, which is well controlled, thyroid disease, which has been well controlled, and he's otherwise healthy and active. He has no history of childhood strabismus, something we always ask about. And then importantly, no other neurodeficits, no headaches, etc. You do his exam, and his vision is 20/20, excellent in both eyes with correction. He has full motility on his exam, except for maybe a trace limitation to abduction in both eyes. On his alternate prism cover test at distance, he has a 12 prism diopter esotropia, and in primary gaze, and maybe it increases a little bit on lateral gazes, but not much. And then at near, he just has this kind of flick of esotropia. His pupils are round, he doesn't have an RAPD. And on cranial nerve exam, it's normal, but kind of looking at him, you know, he does have some mild ptosis and mild dermatochalasis, which all look kind of normal for his age. So we have an audience response questionnaire. Obviously, this differential is very long, but I shortened it to the things that I think are most common and then the things that I don't want to miss. Okay, so if you guys have your audience response questionnaire, if not, you can raise a hand. Who would just say, okay, you're counseling him, you say, well, this is really kind of a divergence insufficiency. The name we're gonna give this throughout the presentation interchangeably is age-related distance esotropia. For A, hands, clicker, okay. B, a unilateral or bilateral 6-nerve palsy. C, thyroid eye disease. And D, myasthenia gravis. So I put, obviously the differential is broad, but I put these things on here because I think it's the most common, and again, the things I wouldn't want to miss. So if you're thinking a unilateral, bilateral 6-nerve palsy, you're really looking for incompetence, maybe other neurodeficits, maybe other medical comorbidities that would make you suspicious for this. Thyroid eye disease, they'd have maybe a typical congested appearance of the orbits with some exophthalmos. They might know that they have a history of thyroid disease, smoking history, really important there. And then for myasthenia gravis, it would be really variable over maybe the course of the day, over the course of your exam, and there might be some associated ptosis. None of those rang a bell for our patient. This is gonna be your straightforward kind of age-related distance esotropia. All right. So what is this phenomenon, this age-related distance esotropia, also called a divergence insufficiency esotropia? Well, it's defined as an acquired comitant esotropia of at least 10 prism diopters, larger at distance than near. Divergence insufficiency, I'm gonna really encourage you guys throughout this talk, really describes a pattern for which there are many causes. And why it's not like a great just like name for a condition is because there really isn't this like accepted divergence center within the brain, although locations in kind of the pons and the midbrain and the CV junction have been proposed. Really, it's more appropriate to call this an age-related distance esotropia, and that's what I'm going to try and convince you today. And then why is this important? Well, there's kind of an umbrella term. It's really a descriptive kind of process, and multiple studies kind of more recently have showed this condition to really be due to mechanical changes in the connective tissues of the orbit, and that's what we're going to focus on. And how common is this? So I say I see this a lot in my patient population. Hands up for patients. You guys see this, right? Hands up. You guys see this? Yeah. So how common is it? And to bring it home locally, retrospective study in the Olmsted County, the Minnesota cohort, to give you an idea or a reminder, you've probably heard of this cohort. It's and basically it's this community where there's little movement, and so they reviewed the medical records of all adults who were 19 years or older, residents of Olmsted County, who are diagnosed with an ESO deviation of at least 2 prism diopters greater at distance than near from January 1985 until December 2004. They retrospectively reviewed these charts. And what they found is that age-related distance esotropia occurred in basically 1 in 10 adults with a new onset strabismus. So really common of the adults you're seeing with a new onset strabismus. And it's more common among women. And then if you're kind of having a sense for, well, is this urgent? Is it, what's the timeline of this? They took a Kaplan-Meier kind of progression and looked at rates of progression. So those, and they define that as more than 6 prism diopters. And so what they did is they looked at patients over time, and 50% of those progressed by more than or equal to 6 prism diopters at 15 years. So to summarize, this is tends to be a slowly progressive esotropia. And I bet your experience with patients is you give them a little prism, that's good for a couple years, they come back, they need a little bit more prism. And so this is kind of the rate of progression that they documented there. But I put this forward because, and maybe it's just moving from North Carolina to here, but I'm seeing a whole lot of this. And when I talk to my colleagues, I think everyone feels like this. And so there was this clinical update about a year ago, the curious case of age-related distance esotropia. Why are diagnoses on the rise? So hands up for those who feel like you're seeing more of this in the past maybe 5 years than 10 years ago. Anyone? Yeah, I agree. And there's data to back this up. So this is a study of all patients who presented with esotropia to a single surgeon over a 40-year period. This is a very famous surgeon, Dr. Guyton. He's at Johns Hopkins. And what they did is they reviewed all their patients who had an onset of strabismus before onset of strabismus. They excluded all those who were young, so those who had an onset before age 10, prior strabismus surgery. Cases of esotropia, obviously, that were associated with other medical conditions, such as thyroid eye disease or neurological issues, were excluded from the study. And then they took all those patients and they labeled them despite their original diagnosis, they retrospectively categorized them as having or not having divergence insufficiency based on a uniform criteria, which they said a distance esotropia that was 5 prism diopters greater than the near. And what they did is they looked at all these patients, and what you can see from this, ooh, do I get a pointer? I might, or maybe I can use this. Does it show up on here if I do that? Yes. Okay, so on this graph here is they looked at all patients, and so in the black lines are all patients with esotropia, and then in the blue kind of bars are those with a divergence insufficiency esotropia. And if you look in the first 20 years, the percent of divergence insufficiency, so we're looking here, esotropia among those with esotropia was only about 12%. And then when they looked in the last 20 years of the practice, so the percentage of divergence insufficiency esotropia compared to all esotropia rose to about 30%. So this is making up a larger percentage of our patients who are presenting with esotropia. And it might be tempting to correlate this, just say this is an aging population, but really this pace outmatches that of an aging population. And so what are possible theories? Well, they hypothesize that there's an association with maybe increasing age and progressive bifocal use. And so if you kind of ask the experts, what are the theories? Why are we seeing this increase in this distance age-related esotropia? And they think it's a number of things, and there's not a lot of data for all of these, but these are hypotheses. So one is that this digital lifestyle that has become more popular, so people are performing more near work on smartphones and on computers. Maybe they're using lenses with inadequate power, so for their ad lenses, they're converging too much over a long period of time, so there's data that if you're really converging, those medial rectus muscles can get tight, leading to distance esotropia. With the kind of more popularity and use of progressive ad lenses, maybe there's improper use of the ad portion, like patients aren't looking far enough down to get that full ad, and so then aren't getting the full power that they need. And then, as we all know, and we talked a little bit about this last year, myopia is also on the rise. So by 2050, 50% of the population is going to be nearsighted. And myopia in and of itself is a risk factor for this type of pattern of esotropia, so there might be some relationship there. And so these are possible causes, but kind of what's maybe happening structurally or anatomically that's leading to this process. So when y'all did your coursework early in your studies, you have these typical Netter images. You have kind of an axial view on top, an axial view on the left and a coronal view on the right of the eye with its eye muscles. But it turns out that's a lot more complicated than that. So the extraocular muscles are really part of this large pulley system. And we've kind of gleaned a lot of understanding of this in the last kind of decade or so. There's been a ton of MRI studies out of UCLA by Dr. Deemer, who's very well known in this area, and looking at how all these connective tissue systems work together. And to be honest, it's way more complicated than I can understand, but to try and simplify, there's basically a network of connective tissue structures, including pulleys. So you can see these over here in blue. That's connecting the globe and the muscle to the orbital tissues. And then there's also connections between these muscles and pulley system called rectus bands. So you can see here, and you'll see this acronym over again. Here you have the lateral rectus muscle, the superior rectus muscle, and you have what they call the LSSR band, or the lateral rectus, superior rectus band. And basically the interactions of these pulleys and rectus bands influence the movements of the eye and play a much larger role in strabismus than what we kind of initially thought. And I think the pivotal paper for me in understanding this and introducing this concept and name, which is saggy eye syndrome, is really this paper here talking about saggy eye syndrome. It's a connective tissue involution that causes a horizontal and vertical strabismus in older patients. Again, you can see by Dr. Deemer and colleagues. And the hypothesis and the kind of data leading up to this is really, well, orbital connective tissue weakens and degenerates with age. And then if you have degeneration of this ligament connecting the lateral rectus and the superior rectus, called the lateral rectus superior rectus band, and these pulley systems, then you can get changes in the globe and the muscles that cause an esotropia and or a vertical strabismus. And they hypothesized that if you had bilateral symmetric shifting, and we're going to talk about what they mean by that, then you get an esotropia with a divergence insufficiency pattern. So what they did is they took patients who had an acquired diplopia, esotropia, and were suspected of having saggy eye syndrome just based on their clinical diagnosis. And they studied 56 orbits of 11 men and 17 women. Mean age was about 70 years old with a clinical diagnosis of saggy eye syndrome. So you have one group saggy eye syndrome. And then they took data from 25 orbits of 14 controls of age-matched controls. So you have older patients with saggy eye syndrome, older patients without a clinical diagnosis of saggy eye syndrome, and they matched them then to a third group also of young patients, average age 23 years. And in addition to this, they kind of looked at the orbital and facial characteristics. And I'm going to show kind of a few demonstrative slides from their study. So this, and they do these really cool MRI studies. So we talk about typical MRI, but they have all these really special coils and the way they set it up at UCLA to get these really high resolution image where you're not focused on the brain or the center of the body, but the eye is the focus. So we call these quasi coronal plane images, or you see quasi axial because they're actually centered on the globe itself. So this is a quasi coronal plane image. On the left, all the way to the left, is the, there it is the young control. You can see very nice. And if you look at that lateral rectus, superior rectus band, it's very kind of thick and robust, and you have really good position compared to this blue horizontal line of the lateral rectus muscle. And then in the middle picture, you have an elderly control participant, and you see elongation of this lateral rectus, superior rectus band. You can see some sagging of this lateral rectus muscle compared to this, again, blue midline line that's crossing the globe. And then you compare this now to the image on the right-hand side. This is your saggy eye syndrome clinical diagnosis. And you can see that this band is completely ruptured, okay? So this band is not thinned, it just ruptured. And then you have a lot of lateral rectus sag, more so compared to the other participants here. There are some other findings. So this is this quasi-axial image. And then on the left, you look at the control and you notice that these muscles are nice thickness, good orientation. And then if you look on the right with the patient with saggy eye syndrome, you can see that this lateral rectus muscle is much thinner and elongated, even the medial rectus a little bit too. And that was a really common finding throughout these patients. And so what they concluded was saggy eye syndrome commonly is associated with blepharotosis and superior sulcus changes. Again, remember they looked at kind of facial anatomy and facial changes. That the inferior lateral rectus pulley displacement was significantly more common in the saggy eye syndrome patients, as well as other kind of pulley changes and muscle changes. And then you saw that elongation of the rectus muscles. And what they hypothesized and found to be true is that when there was a symmetrical sag in the lateral rectus, that was associated with a divergence insufficiency esotropia. But as you might expect, if there's this asymmetric sag in those muscles, then this was of greater than 1 millimeter, what they found when they were measuring these orbital images. Well, that was more associated with a cyclovertical strabismus, right? So that's why you can see these patients, and they have some variability. Are they just a straight horizontal? If you look really closely, is there a vertical component or maybe even a torsional component to it? And most importantly, and this is what I think about when I think about saggy eye syndrome patients, is the majority, so 91% of patients had rupture of this lateral rectus superior rectus band. Okay, we're gonna shift a little bit. This is case 2. This is a 70-year-old female. She presents with 1 year of worsening diplopia at distance. She has kind of a diagonal diplopia, so horizontal and vertical component. It's intermittent diplopia at near. It resolves as she closes either eye. Similar to our last gentleman, she has a history of hypertension, which is well controlled, thyroid disease that's well controlled, but otherwise healthy and active. She has no history of childhood strabismus. But she mentioned she had a history of myopia prior to her cataract surgery, and her past surgical history is notable for cataract surgery. All right. And so her visual acuity, 20/20 in both eyes with correction. Her motility is, she does have this limitation to abduction, a -1 on both sides, and elevation, -1 on both sides. You do a cover test, and she has this 35 prism diopter esotropia, 5 prism diopter left hypotropia and primary gaze, and these increase a little bit on lateral gaze, and at near she just has this intermittent 15 prism diopter esotropia. Her exam, her pupils are equal, round, reacted to light, no RAPD. Again, on cranial nerve exam, this is otherwise normal. She has a deep superior sulcus in both eyes. And so we go back to our differential, the most common things, and then the things you really wouldn't want to miss. And as you're asking a little bit more questions, and you're like, okay, well, she was nearsighted before cataract surgery. How nearsighted were you? And it's funny to me, patients often don't remember it. They go, I don't know. I was wearing really thick, I was wearing Coke bottle glasses. You go, okay. And then you're doing your exam, of course, and she has this really myopic looking fundus. She has peripapillary atrophy. You can see the choroidal vessels through a very thin retina, and you go, okay, she's probably really nearsighted. We don't know how much, but she was. And so then if I see a patient like this, then the other thing that pops onto my mind, we talked about saggy eye syndrome, is something called heavy eye syndrome. Who's heard of heavy eye syndrome? Hands up? Anyone? Good? A couple? Good. Okay, at the end, you all will have hands up. So heavy eye syndrome, similar to saggy eye, it's this progressive esotropia with or without a hypotropia or a vertical component. They have limited abduction, supraduction, and can develop in individuals with high myopia. And this has been known for a long time, so there's been case reports dating back into the 60s. This particular case report's by a Dr. Bagshaw. She describes 2 cases of a vertical and horizontal strabismus in the setting of high myopia with limitation to the ocular movements. In its really severe form, and we're going to come back around and talk about this a little bit more, it's called myopic strabismus fixus. And in the late 90s, MRI, similar to the saggy eye syndrome, but a little predates that, MRI was used to help elucidate the cause of this deviation in patients that were highly myopic. So these 2 papers were kind of the first to come out. And then, and basically they analyzed the path of the extraocular muscles quantitatively using MRI in these highly myopic individuals with and without restricted eye motility versus kind of controls. And in the patients who had this really high axial myopia, they found displacement of all the rectus muscles. And then particularly, they had lateral rectus displacement inferiorly, and then superior rectus displacement nasally. And they hypothesized, because of the really severe lateral rectus displacement inferiorly, that this was probably the major pathophysiological factor in this restrictive motility disorder that was being seen in highly myopic individuals. And so to kind of like put this all together, and a lot of this work was done in Asia by Yokoyama and colleagues, but to give it more of like a significant definition, they came up with this way to look at these eyes. So these are coronal images, and instead of just saying, okay, well, the superior rectus is displaced nasally and the inferior rectus, or the lateral rectus is displaced inferiorly, maybe we can like formalize what this means. And so they said, well, you can draw this angle between the two centered on the globe. And that angle, there's like a normal range, obviously, and then a really abnormal range, as you can then see on this right-hand side. This is preoperative pictures of a patient who has really this severe heavy eye syndrome. I'd almost say myopic strabismus fixus. And what you can see in these coronal images, first in the superior image, you can see she has a significant limitation to abduction and superadduction, more in the left eye than the right eye. And then when you look at the MRI coronal images, you can see that this patient, if this is a normal angle over here on the left, you can see this patient has this severely abnormal angle. And so on this right eye, this angle is about 190 degrees, and on the left, it's about 202 degrees, and this is significant displacement of this lateral rectus inferiorly, and again, the superior rectus nasally. Okay. But how do you kind of separate these two things out, right? Like, is it like a spectrum? Is it two entirely disease processes that have to do with changes in the connective tissue of the orbit in different ways? And I really like this paper, also by Deemer and colleagues, that looked at heavy eye syndrome versus saggy eye syndrome in patients with high myopia. Well, what does that mean? Well, they took 11 patients who were highly myopic, and they underwent ophthalmologic examination, orbital imaging to assess the quantitative orbital anatomy, but they didn't have any diagnosis leading into this. So they take these 11 patients, all with similar axial length and myopia. 5 were determined to have heavy eye, just based on the MRI findings. 5 were determined to have heavy eye syndrome, and 6 were determined to have saggy eye syndrome. And again, the mean axial length was similar between the two groups, but the average distance esotropia was much larger in the heavy eye syndrome, as well as a vertical deviation compared to those with saggy eye syndrome. And what you can see here, and the top is this an example of a patient with the heavy eye syndrome, and this was found in all 5 patients with heavy eye syndrome had this superior temporal globe prolapse. Do you see that over here where this white arrow is? So the globe is actually protruding, but the lateral rectus, superior rectus band was thinned in most of the orbits, but only ruptured in 2. So the predominant feature in heavy eye syndrome is really this superior displacement of the whole globe. And then when you looked at the patients over here with and had a much larger angle of difference, obviously, between the superior rectus and lateral rectus. And then if you look over here in the saggy eye patient here on the bottom in the sequential images, you'll see that the kind of defining feature here, which we've alluded to previously, is rupture of this lateral rectus, superior rectus band, and maybe a little protrusion of the globe, but not as significant as compared to the heavy eye syndrome. And then again, just kind of quantifying this angle of difference, those in the heavy eye syndrome patients was much larger at 121 degrees, and significantly different than those with saggy eye syndrome with 104 degrees. So I put out to you, I've talked to you about saggy eye syndrome, heavy eye syndrome. We're going to talk about a couple other conditions kind of in this spectrum. But why does this matter? Why does this matter? Why should you care? I think that we can be more specific when we talk about age-related esotropia. And I think this is helpful for us as clinicians, and I think it's helpful for patients. So whenever a patient comes to me, that y'all send to me, who's an adult with strabismus, the first thing I try and answer is, why is this happening? Like, why is this happening to you? And secondly, what can we do about it? And I think being more specific in our diagnosis can help with both of those things, right? So if you see this really typical pattern, it reassures me to reassure them that I don't think they need neuroimaging for looking for like an alternative cause. And then it's really helpful then on the treatment side when I'm thinking about what is your rate of progression, are you going to do well in prism glasses, or is this something that needs to be treated surgically? And most importantly, if it's treated surgically, the type of condition helps inform the surgery that we're going to do, and we're going to talk about that next. So The surgical procedure for correcting this globe dislocation in a highly myopic individual with heavy eye syndrome is going to be very different than the surgery I'm going to do for your typical saggy eye syndrome patient or your typical divergence insufficiency esotropia. And this procedure in particular is called a loop myopexy. And again, Yokoyama and colleagues pioneered this in Asia. And is instead of kind of just resecting or recessing muscles, what you're actually doing is trying to restore like the normal anatomy of where those muscles are going. So, and I'm going to show you lots of videos of this, but you can see here, this is the lateral rectus, this is the superior rectus, the paths of the muscle are not typical. And when you do a loop myopexy is you kind of pull these muscles together to restore their normal anatomic locations. This is, on the right, this is a pre-op and post-op image, status post a loop myopexy for this patient in both eyes. And this is the pre-op image. You can see the superior temporal dislocation of the globe, the displacement of those muscles inferiorly and nasally. And then you can see after the loop myopexy, you just like a much more normal anatomic look of both the globe and the muscles. So we're going to start with a case presentation. So this is a lady who came to see us. It's a little bit different because, as you'll see, she also has a glaucoma drainage device. But she comes to clinic, and she has this left esotropia of about 20, this left hypotropia of about 30. It's really large. She has this huge limitation to both abduction and elevation. Let's see. How do I play the video? Oh, there we go. Okay, so you can see this is, and she has a large bleb over there. We're going to talk about that, but you can see that looks great and when she's looking to the right, but has a significant limitation to her ability to abduct that eye. There's that giant bleb over there that's causing a restriction, and she has a limitation to elevation as well. Okay, and I'm going to talk you through what we did for her surgery. So this was a revision of her glaucoma drainage device, which we did with our glaucoma colleagues at the time, and then also in it. So we're opening up the conjunctiva here over the plate. They're kind of pulling out the plate. They're trimming the plate so that you can get some issues with scarring and also just displacement of the muscles from the size of the plate. They're taking out the capsule here just because that was a large mass effect pushing things out of the way. They're going to tie off the tube so the eye doesn't deflate while we're operating. And then it's our turn. We're looking first for the superior rectus muscle. It's a little bit of scarring, but not much. So you can see here we're hooking the superior rectus muscle, isolating that. Looks pretty good, but a little bit nasally displaced from this large mass effect here. We're trying to find the lateral rectus over here. Much more scarring on this side. So you'll see us really working. Trying to get through the scar tissue, making some success there, good, getting through, getting into pocket. You see those muscle fibers right there? That's actually the inferior oblique. Here we've hooked the lateral rectus. And then what you're gonna see is you see how this course of the lateral rectus is so inferiorly displaced. So that's totally abnormal anatomy. You can see here the insertion of the inferior oblique. You shouldn't really be able to see that. So we're taking about 12 millimeters back. We're taking a central bite through the lateral rectus. We're gonna come back up to the superior rectus and do similarly on this side. Take a bite through the muscle belly about 12 millimeters back. We're gonna tie those together. And what you're gonna see is that the lateral rectus comes up as we do this. We do this in a permanent suture. As you can imagine, we don't want this to dissolve in 8 to 10 weeks. So we're pulling that together, making sure we like where everything is, finalizing that knot there. All right. And this was the patient on post-op day 1. So we also did a medial rectus recession at the same time. That's really common. But compared to her pre-op photos, you can see she has this huge improvement in her ability to abduct that eye, move it out, and elevate that eye supraduct. All right. And then this was another patient who presented to me. He's a 53-year-old gentleman who has trisomy 21. He was here for evaluation of both eyes crossing. He was here with his sister caregiver. And she said that the left eye had turned in for about 30 years, but now the right eye was turning into, was really affecting his quality of life and his ability to do activities. He'd had a history of cataract surgery and a small bowel obstruction. He was otherwise healthy. And this was his exam. So this is a really severe case of heavy eye syndrome. I would call this a myopic strabismus fixus. You've heard me say that a couple of times. His vision was 20/100, 20/80. He had centered lenses in both eyes, some PCO. He had really myopic looking fundus with tilted nerve and retina with myopic changes. He had this huge angle esotropia. So when it's this large, we can't really even measure it. We're doing it based on what's called Krimsky. We're holding up lenses and looking at the light reflex, but he had this -4 abduction deficit in both eyes. And really can't elevate either. So you can see him trying to look around, and he's got this huge limitation. Oh, sorry, there's a little bit of audio. We're trying to get him to look to demonstrate for everyone, but as you can see, it's really limited. Trying to look up here, trying to look over. Nope, can't look up. That's as far as he gets. So, so we took him to surgery, and you're gonna see, I wanted to give 2 videos so you can see this a couple of times. And here we're just making what's called a radial incision between the superior rectus and the lateral rectus muscle. We're entering tenons. We're elongating this incision just to give us better access because we're going to put those sutures pretty far back. Here we're hooking the lateral rectus muscle. You can see a couple of things. 1, it's inferiorly displaced. 2, you see this kind of dark choroid there. So he has a staphyloma. He has really thin retina. We're going pretty far back, getting a good kind of bite just through the muscle belly. And again, one of the things I really like about this procedure in these really highly myopic individuals with thin retina is that you're not having to put any sutures through the sclera, right? You're just putting these 2 muscles together to restore their normal anatomy. Here's the superior rectus. We're going 12 millimeters back, again, putting in a suture at the muscle belly, about halfway thickness through. And then just like the last case, we're going to pull these together to restore a more correct anatomic location of those 2 muscles. And we will do this in combination with a recession or weakening procedure of the medial rectus muscle. In really severe cases, you have to what's called extirpate potentially that medial rectus muscle and just cut it off. We're closing conjunctiva here. And we're going to do one more thing, just because he had this eye turn in for so long. Sometimes we'll put what's called a traction suture to keep the eye as it's healing for the first couple days in its correct kind of anatomic position, just so as it's healing, you're giving it all the advantage to maintain its correct alignment. And so we're just putting in this additional suture here through the kind of conch tissue. They probably shouldn't have put this session right at breakfast time. All right. Okay. So this is him on post-op day 1, and we did this on both sides. So we did a loop myopexy on both sides, and where we assessed both medial rectus muscles. And look at this huge, I don't know if you can see it, and you might want to dim the lights, but you can see he has this, first of all, his alignment looks so much better. But second of all, he has this huge improvement in his ability to abduct the eyes and elevate the eyes. Okay. And as I was going through the literature, there's actually this myopic strabismus fixus, this really severe form of a heavy eye syndrome, is actually more common in patients with trisomy 21. We know that our patients with Down syndrome have higher refractive error at baseline when they do have refractive error, but it's more common. And so again, it's associated, this myopic strabismus fixus, it's associated with high myopia. It's this progressive extreme esotropia and hypertropia with restricted abduction and superduction, as you saw in his initial movement videos. And then it's related, again, to the supratemporal protrusion of the elongated eye through the muscle cone. And you guys got a picture of that as I was going through that video, and I'm going to show it again in another place, and then resulting, again, kind of similar to heavy eye syndrome in this displacement of the lateral rectus muscles down and the superior rectus muscle nasally. And so we've talked about saggy eye syndrome, heavy eye syndrome, but a subset of these, and I'd almost categorize our last patient as that, is what we call a knobby eye syndrome. And again, this was kind of characterized by Joe Deemer at UCLA, and what he did is he looked at the MRI orbits of 36 patients that were highly myopic, and he compared those to 33 normal eyes. The average axial length for the myopes was 28.8 millimeters, and all but 2 of the myopes had esotropia strabismus. And he looked at the globes, and 10 myopic eyes were spherical, and 15 of the myopic globes had this diffuse posterior staphyloma or equatorial staphyloma, or had a combination of the two. And I'm going to show some representative images here. So this is an axial MRI through an equatorial staphyloma. You can see those with the horizontal arrows. So you can see this kind of protrusion here. Here you have this axial above and then quasi-coronal below, and it shows an equatorial and posterior staphyloma, denoted by the arrows. And then in this really severe case, you have on the top the axial, in the middle the quasi-coronal, and then on the bottom this quasi-sagittal views of the orbit, and in this highly myopic individual, and they have like prominent knobby posterior staphyloma, and I hope you can see that here, especially on that picture up there. As you can imagine, based on the location of where the staphyloma is, similar to our case with the glaucoma valve in that large bleb, it's going to really displace these muscles and cause some really severe strabismus. And again, this is similar, this is what you see when you're looking in on one of these patients, is they have this staphyloma, it's very thin, you see choroid. Hands up for who wants to put a needle through that really thin sclera, not me. And this is, and not only is this a safer procedure for them, but it's a better one in terms of restoring their normal anatomy. So in summary, I would hope that you all after this could consider a more specific diagnosis when you're seeing these patients with age-related distance esotropia, whether that's a saggy eye syndrome or thinking about something like heavy eye syndrome on your diagnosis. Especially consider saggy eye syndrome if they have a history of high myopia. But again, as we saw, not all those with high myopia have a heavy eye syndrome, so those with myopia can also just have your run-of-the-mill saggy eye syndrome. Knobby eye syndrome is, again, another subset of these patients. MRI, it's reassuring to me. I see these patients and I go, okay, well, I don't think you need an MRI to look for some neurologic cause like a tumor or something like that. But an MRI is really helpful for me sometimes if I'm then planning surgery to say, okay, is this a heavy eye syndrome? Is the globe really displaced? Do we need to think about a myopexy versus your lateral rectus resection and a medial rectus recession? So considering lateral rectus, superior rectus myopexy, if there's significant inferior displacement of that lateral rectus muscle. All right, and I'm happy to take any questions.